Hello everyone. This class is about airway anatomy and we will discuss the important points regarding airway anatomy as an anesthesiologist. So, why do you need to understand the airway anatomy? It is important to understand airway anatomy because as an anesthesiologist, you will be expected to maintain the patient's airway at all times and any time during the surgery. So what is maintaining the airway? So you can see the first point here. The fundamental responsibility of the anesthesiologist is to maintain adequate gas exchange in a patient. So what do you mean by gas exchange? So gas exchange is nothing but taking care of the patient's ventilation and oxygenation. So oxygenation is nothing but getting oxygen to the patient. Ventilation is nothing but excreting the carbon dioxide that is present in the blood of the patient. So both consist of gas exchange. So you're giving oxygen and taking out of the carbon dioxide. So this has to be maintained at all times to maintain homeostasis. And why an anesthesiologist need to maintain an airway at all times? Because the patient's gas exchange depends upon the airway patency. So the airway from your nose to your trachea, the pathway should be kept open. So that responsibility falls to the anesthesiologist during the surgery. And sometimes even the surgery may be conducted under spinal anesthesia, but still the anesthesiologist should be very confident that he will be able to intubate if something happens, like if the patient gone in for an anaphylactic shock, or if the patient gone in for um, an intraoperative complication, anything like that. So why we need to do so? Because failure to do so even for a few minutes will lead to either brain damage or death. So that is very medico-legally important. So regarding brain damage, see, brain is an organ which depends upon oxygen and glucose for its normal function, and it cannot even survive few seconds without oxygen. Like a person will become unconscious if the total supply to the brain is cut off for 5 to 10 seconds, and they will lose consciousness. And if the oxygen supply to the brain is cut off for almost 6 minutes, the neurons will start dying. So that is called as neuron death time. So in a patient who got arrested, and if you revive them within 6 minutes, or if you given us adequate CPR, then the brain can be kept alive. But if the CPR is not adequate, and if the revival is after 6 minutes, then they could go in for brain damage. They could go in for brain death. So similarly, a patient in surgery, we need to maintain their blood supply to the brain throughout the times. I'll give you one more example. So in a patient who had a stroke means there is loss of blood supply to the brain. So in a patient who had stroke, for every minute after the stroke, they will be losing around 1.9 billion neurons per minute. So our brain has 100 billion neurons, billion. And they losing each minute 1.9 billion neurons is a lot, and that is equivalent to almost 3.6 years of their life as a normal person. So a normal person will also start losing neurons as they age, but the amount of neurons lost after stroke is equivalent to 3.6 years per hour. So that is very dangerous, and you need to maintain the blood supply to the brain after brain damage. Now coming on to airway management. So how do you manage the airway? So the three common ways to maintain a airway patency and gas exchange to take place are these three things: mask ventilation, supraglottic airway insertion, and endotracheal intubation. So first we'll see endotracheal intubation. Most of you would have been familiar with endotracheal intubation because of your house surgency. So it's nothing but placing an endotracheal tube through the mouth into the trachea. So that's it. So that is a definitive airway of the patient. There is an MCQ question. They might ask you what is the definitive airway. Endotracheal intubation is the definitive airway. It is called definitive airway because through endotracheal intubation we can secure the airway, we can prevent aspiration, and we can keep the airway patent for a long time. Now mask ventilation. So mask ventilation is nothing but you just keep an anatomical face mask over the patient's face, and you have a tight seal around the mask, and you connect this mask to either an ambu bag or a circuit, anesthesia circuit, and you can ventilate the patient. The air will enter into the normal anatomical passages of the patient and go into the lungs. So this is mask ventilation, and this mask ventilation can be done with the help of additional things like airway opening maneuvers like jaw thrust, chin lift, and upper airway opening devices like airways. So airway kept open with gases delivered with the tight fitting face mask with or without jaw thrust, chin lift and upper airway devices. Supraglottic airway, gases delivered through a supraglottic airway such as LMA. So supraglottic airway, simply I'll explain. So glottis is a part of the glottis is something called as, so what do you mean by glottis? Glottis is nothing but laryngeal opening. So when you keep a device above the laryngeal opening, that is supraglottic. Supra means above glottic. So above the laryngeal opening, that is called a supraglottic airway. When you insert the tube inside the larynx, that is called as endotracheal intubation. So we will see supraglottic airway in a separate class. We will see endotracheal intubation in a separate class, mask ventilation in a separate class. In this class, we are going to see only the anatomy of airway. So airway consists of upper respiratory tract and lower respiratory tract. So what do you mean by upper respiratory tract? So it's very simple. So we already saw that the opening of the larynx is called as glottis. So the part above the glottis is called as so it is called as upper airway. The part below the glottis is called as lower airway. So from nose to laryngeal opening, it is called as upper airway. From the laryngeal opening to the end, to the terminal respiratory bronchiole, it is called as lower airway. And again, this lower airway is divided into conducting portions and respiratory portion. So conducting portion is nothing but it transports air. From the name itself, it is there. It transports air, and it includes nose, nasal cavity, pharynx, larynx, trachea, and progressively smaller airways from the primary bronchi to the terminal bronchiole. I'm sorry, the entire airway is divided into conducting portion and respiratory portion. So respiratory portion is nothing but it carries out gas exchange. So the oxygenation and ventilation takes place in this part, and it is composed of small airways called respiratory bronchioles, alveolar ducts and alveolar sacs. And it consists of alveoli. So this is called as respiratory portion. So now I want to tell you that the conducting portion, it is divided into 23 divisions. So from the trachea is considered as 0 division. From trachea, like bronchi, primary bronchi, secondary bronchi, segmental bronchi, like that, it divides into 16 portions in which there is no air exchange happens. So those are conductive portions. The last 8 segments are called as respiratory portion, in which the air exchange occurs. This is an MCQ question, you should remember. We will discuss more about these physiological points in respiratory physiology class. I will take respiratory physiology from an anesthetist point of view. The basic physiology class will be dealt by physiology faculty. So now again, so up to this portion, the laryngeal opening, it is called as upper respiratory tract, and below this portion from the trachea to the end of to the alveoli, it is called as lower respiratory tract. Upper airway. So the parts of the respiratory system lying outside the thorax or above the sternal angle, the airway above the glottis or vocal cords. We already know these things. So the parts are nose, nasal cavity and paranasal sinuses, pharynx and larynx. So first we will see about the paranasal nasal cavity. So this is the nasal cavity. So nasal cavity is lined by pseudociliated columnar epithelium, and it consists of the paranasal sinuses, that is frontal, sphenoidal, maxilla, and your ethmoid sinuses. And so this nasal cavity, exactly opposite to the nasal cavity, lies the nasopharynx. And there are certain functions to these parts, that is the paranasal sinuses provide your resonance to the voice, and the nasal cavity consists of hairs and follicles, hairs and cilia, which prevents the dust particles from entering into the body, and it acts as a primary immune mechanism. For paranasal sinuses, we have 4 groups of sinuses: frontal, ethmoidal, sphenoidal and maxillary sinuses. So it decreases the skull bone weight, it warms and moistens and filters the incoming air, it adds resonance to the voice, communicate with the nasal cavity with ducts, and when these ducts get obstructed or when there is an infection in the sinus, that leads to sinusitis, which becomes chronic and which can be repaired only by surgery. So the line by stratified ciliated columnar epithelium, we know that. So these are all the paranasal sinuses given in pairs. Now coming on to pharynx. So pharynx is a conical fibromuscular tube. So it is made up of muscles and fibrous tissue. It is a conical structure extending from the base of the skull. So this this is larynx. So this yellow part until this so this is pharynx. So this from this yellow part to this larynx. So it extends from the base of the skull. So this is called as basi-occiput. This is a portion of the occipital bone which forms the base of the skull. That is called as basi-occiput. And ends at the level of the cricopharynx. So at the level of the cricoid cartilage, it ends. So extends from the skull, the basic occiput or basic sphena to the lower end of the cricoid cartilage and continues with the esophagus. So width at the base is 3.5 centimeter and width at the pharyngoesophageal junction is 1.5 centimeters. So nothing but pharynx, esophagus, the junction is called as pharyngoesophageal junction or otherwise called as cricopharynx. So there is an clinically important point about this cricopharyngeal junction. I'll tell you what it is. So the narrowest portion of the entire gastrointestinal tract of a human being is cricopharynx. So the junction is only 1.5 centimeters. So whenever there is a foreign body, like say someone has injected a foreign body like coin or some water bottle cap or anything like that, it will get lodged in the cricopharynx. So the anatomical importance is if the foreign body passed the cricopharynx and it is inside the GET, there is a very good chance that that foreign body will come out in its natural pathway. That is, it will come out of the patient's body through feces. So the narrowest part of the body is cricopharynx. The other narrowest part is your ileocecal junction. So if it passes through these two things, it will definitely come out. Nasopharynx. Now, we already saw the portion lying behind the nasal cavity is called as nasopharynx. So, the pharynx is divided into nasopharynx, oropharynx, and cricopharynx, or and laryngopharynx. So, all three parts consist of the entire pharynx. And the nasopharynx lies behind the nasal cavities. It extends from the base of the skull to the soft palate or hard palate. The lining is pseudostratified ciliated columnar epithelium. Oropharynx, it lies exactly behind the oral cavity, and it extends from the hard palate plane to the plane of the hyoid bone. And laryngopharynx. So this is the cross section of the pharynx, and we are looking at the pharynx from the behind. So we made an incision at the central part of the pharynx and we split open the layers. Now we are looking at it from the behind. So this is the nasal cavity. You can see the turbinates here, and exactly behind the nasal cavity is called as nasopharynx. This portion, it starts from the basic occiput to the soft palate, and the oropharynx, it starts from the hard palate to the hyoid bone. And this is the tongue. You can see the papillas of the tongue. You can see the ovula and the fossil pillars. Exactly behind that is your oropharynx, and so this portion is called as hypopharynx or called as laryngopharynx. So it lies behind the larynx. It is called as hypopharynx or laryngopharynx, and below this esophagus starts, and the pharynx and the esophageal junction is called as cricopharynx. This is the narrowest portion of the pharynx. And this is an important MCQ question. Pharynx lies opposite to C3 to C6 of the vertebra. So that is very important. Most of the time it has been asked as an MCQ. And now, so this structure is called as epiglottis. This opening is the glottic opening which leads into the larynx and trachea. Now coming on to larynx. So laryngeal anatomy and laryngeal palsies and laryngeal functions will be dealt in a separate class. In this class we will just see some basics about larynx. So larynx consists of 3 paired cartilages and 3 unpaired cartilages. So unpaired cartilages are this leaf shaped epiglottic cartilage and this shield shaped thyroid cartilage, and we have a cricoid cartilage. So these are midline cartilages, these are unpaired cartilages, and we have paired cartilages called as corniculate, cuneiform and arytenoid cartilages. These cartilages lies in the either side of the midline along the cricoid cartilage, and we have ligaments extending from these arytenoid cartilages to the thyroid cartilage, that is called as your vocal ligament, and the mucosa covering the ligaments are called as folds. Now, so this is the epiglottis. This is a view from the above. So this is the epiglottis. So this is the posterior region. This is the anterior region. So this is posterior commissure. This is anterior commissure. This is epiglottis. This is glottis in a closed position. This is glottis in a open cadaveric position. So this is the root of the tongue. So the space between the tongue and the epiglottis is called as vallicula. This is an important MCQ question. Many times this MCQ question has been asked. The importance of vallicula is while you are intubating the patient with the laryngoscope, you put the tip of the blade into the vallicula and you start lift the tongue. That is how you intubate. We'll see intubation in a separate class. Now I need you to remember this picture. So this is the view that you would see while intubating the patient. So this is your epiglottis, and the tip of the blade will be kept between epiglottis and the tongue, and you'll be lifting. So this is the view of the vocal cord opening, that is glottis. So this is in a cadaveric position. This means the patient has been paralyzed with muscle relaxant and they have no tone in their larynx. So that is why it came to the cadaveric position. This position can be seen either the patient has been either the patient has died, or the muscle relaxants has been given. So these tiny projections are cuneiform, corniculate and arytenoid cartilages, and when you have to put the tube into this opening.